Hello and welcome to Read Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Read Scholars. Today, I am joined by Dr. Nwando Olayiwola, who is a family physician and public health professional, chair and professor in the Department of Family and Community Medicine at the Ohio University Wexner Medical Center. She received her bachelor's degree in MD from the Ohio State before completing her residency in family and community medicine at Columbia University in New York. Dr. Olayiwola is also a Reed Scholar, completing the Commonwealth Fund Fellowship in Minority Health Policy in 2005. In addition to being a clinician and researcher, she is also the mother of two boys. I will put a link to her full bio in the listen notes because her accolades are numerous, and I would love to be able to share all of those with you. But for now, welcome. How are you? How is life treating you?
Thank you. It's great to be here. And I have to issue one small correction to that. I've
Please.
got a boy and a girl.
Oh, I'm
So
sorry.
just in case
Oh, your children are gonna be so mad at me. I'm sorry.
but it's great to be here. It's so nice to see you, Dr. Fleming.
That's a big correction, not a small correction. Send them my deepest apologies. So how have things been for you the last few months? I'm sure busy.
Yeah, things have been busy, crazy. But I think moments call for people to be in the right place at the right time, and I feel definitely very blessed that I am where I am in the moment that we're in. But it's been very busy. Yeah, been very busy.
And so your transition back to the Ohio State is relatively recent, but I wanted you to share a little bit about your journey because you've worked all over the place, like across the country. You've done international work.
Yeah.
So share with our listeners a little bit about your journey and why you chose family medicine, and then how family medicine took you to those different places.
Sure. Yeah, so I chose family medicine when I was in medical school, largely because I envisioned a career in which I would be doing a lot of work globally, and internationally, and really wanted a specialty that would allow me to have full range of skills in a broad range of things in medicine. And I felt like in family medicine I'd be able to, leave and go to Nigeria and be able to be relevant and valuable, and I'd be able to go to England and be able to be valuable. And so I just felt like it was a really good profession for that kind of pursuit of global care. But also, honestly, I really liked almost every single thing I did in medical school. So I loved internal medicine, I loved pediatrics, I loved OB, loved so many things that I felt like it was going to be hard to choose one of them. So I think the combination of the variety and the family medicine kind of skill set and expertise box, and the ability to be able to be mobile, was really why I chose it. So as far as my journey, once I finished the fellowship, the Commonwealth Fund Fellowship, I moved to Connecticut and I took a job in a community health center, where I was a full-time primary care physician working in Connecticut's largest federally qualified health center system at one site. I went there because I felt like community health was really the community health movement really resonated with my own values, and the notion of providing care to people regardless of their ability to pay was really important to me. And I felt like community health allowed for this intersection between delivery of clinical care, but also public health and social justice, and community engagement. So I went there, initially planning to be there for a couple of years, and then ended up being there for 8. And in the course of that time, I became the chief medical officer for the network, which meant that I had oversight of about 200 clinicians and physicians and other clinicians, and 12 medical sites, and got a lot of great opportunity and kind of on the ground learning around physician leadership and management, and development of physicians, pipeline building, practice-based research, and innovation. And I kind of got started there. My interest in kind of technology innovation, which is a lot of the work that I do, really was birthed out of that work in the community health center when I was struggling to get patients access to specialty care, and struggling to get patients with diabetes the retinal screens that they needed, and all those challenges that we had because our patients were predominantly insured through Medicaid, and then a huge portion were uninsured entirely. So just being able to see that kind of the need for technology to bridge gaps in care kind of emerge out of being a physician in that environment. And then from there, I was doing a lot of work on primary care practice redesign, technology-enabled primary care, and I was recruited to go to UCSF, so University of California, San Francisco, to lead their Center for Excellence in Primary Care. And that center was relatively young, but they were really looking for someone that had experience with transforming the way primary care was delivered, and not just from a theoretical framework, but actually had actually transformed clinical sites and redesigned clinical delivery systems. And so it was an interesting time. Our children were young at that moment, and so never thought I was going to move to California, but we did decide to move and take that position. And I thought it was really great that the center was situated in the Department of Family and Community Medicine, but had a lot of opportunity to reach out and connect with other groups and departments and throughout the university. And so during that period, um, I was able to do one of the most compelling parts of my career. I would say two major things have been really, really fundamental in my career. One was doing the Commonwealth Fund Fellowship, and I would say the second was doing the Marshall Memorial Fellowship, which is a fellowship of the German Marshall Fund of the U.S. And actually, two of our Reed Scholar alums had done it before me, and I had heard about it from them. And you can be nominated by someone who has done it before. And so it was actually one of our Reed Scholars, Tam Duperval, that nominated me for it. And Chandi Ghosh was great at giving me a lot of advice and the application to prepare me. So literally, again, those two really important moments in my life were connected in that way. But I went to Europe for that. It's a transatlantic leadership fellowship where they kind of prepare fellows from Europe and fellows from America to be able to lead in efforts that are more international. And I got a chance to go to spend a number of weeks in Europe and go to a number of different countries and learn a lot more about social medicine and kind of how they approach medicine for different populations in different countries in Europe. And when I came back, I knew that I had to really use the platform that I had to do more internationally. And so had already started some work before them, but somehow just kind of got, and I can't really think of what started it all, but got myself into kind of international primary care delivery and helping healthcare systems build foundational primary care components. And so that work, took me to a number of places, Ireland, Singapore, Australia, New Zealand, United Arab Emirates, Nigeria. So a lot of different efforts around kind of foundational primary care delivery. And that was, and it seemed like it made sense with the kind of larger primary care transformation work I was doing at UCSF. So it all kind of came together. And then I also was continuing that work in technology innovation, and that really never went away. And actually kind of magnified that work when I got to the center at UCSF, just because there was so much work. And as people were kind of reaching out to the center for guidance on redesigning primary care, it became very obvious. California was pushing for a lot of health-related technology effort, and organizations across the country, across the world were really interested in that. And so I started to do a lot more of that work as well, which led me to the next thing. My stint in a health technology company. Again, I will just say, if there's any theme that you can pull out from what I'm saying, is like, none of these things were things that I was like, okay, this is what I'm going to do with my career. Like, this is where I'm going to go. It just kind of, the work continued to kind of breed more work and opportunities. And because I was so heavily involved in this electronic consultation space and had done like the first national randomized controlled trial on electronic consultations between primary care and specialty care, and was just really visible in that space, one of the big e-consult companies to reach out to me, called Rubicon MD, to be an advisor for them. And I really don't know how we went from me being an advisor to me actually kind of leaving my role at UCSF and joining the team as their chief clinical transformation officer. And my goal was to really help them figure out how to really much more fluidly integrate this technology into primary care settings, to build out kind of a continuing medical education component through electronic consults and things like that. And so I worked for, I took a major career detour, took a major pay cut, and took a major risk. And I guess I would say that time was probably the time I felt like the last time, age-wise, probably the last time I'd take a big risk like that. The age of our kids, my age, my mentality was pretty good. And I thought it was actually a fascinating move that I made, because I don't think I would have ever kind of had a professional reason to work that closely with like engineers and product developers and business development people and folks that really are not in my day-to-day orbit.
Right.
Um, so it's fantastic, and I think that was great. I continued working at UCSF doing refugee related health that I'd been doing the whole time, and then from there I was recruited back home to Columbus, Ohio. I was chair of the Department of Family Medicine, which we just renamed Family and Community Medicine a few weeks ago. So, yeah, that's my story.
Wow, what a story. That is exciting. I'd like to lead with people's journey because I think it's so fascinating. Um, and most of the people we speak to don't have a straight line course, right?
Yeah,
I
yeah,
think that's what's fun about your capacity in being a physician, right? That we can do so many different things and affect change in so many different ways. And we have to meet people where they are. And sometimes where they are is improving their access to technology, right? But there's lots of different ways. So I appreciate you sharing that journey with us. And kind of just in a natural transition, now that you're chair of a large department in a large academic center in the midst of a pandemic, I'm sure that has brought out a different set of leadership skills for you. So tell us a little bit about that transition and your challenges and I guess your personal successes over the past few months.
yeah, yeah. No, I would definitely say that. Again, nothing has been scripted or planned, and certainly, coming on to be chair of such a large department and such a large academic health center during this moment in time is nothing that I think I could have ever seen coming. But I'll say that so many other things that led up to me being here kind of prepared me to be able to survive and maybe even thrive in this moment. One was that leading physicians and leading teams that support with physicians and work with physicians is something that I kind of got the skills in doing early on, but leading them through crisis. So I was the chief medical officer of that FQHC network that I mentioned during H1N1,
Mm,
and I was relatively new in that role as chief medical officer when that happened. Again, in terms of scale, nothing like this,
right.
but certainly did require a lot of kind of myth dispelling
Mm,
and trying to figure out how do you lead and how do you stay on top of evidence and data that was emerging literally every second, and is the vaccine safe or not? Should we get it or not? And all those kind of things I think were really important to and became relevant during this period. Um, the COVID-19 pandemic, I think from a pure like clinical leadership expertise standpoint, was the one I would probably say I was more prepared for. I think the aftermath of the George Floyd, Breonna Taylor, Ahmaud Arbery, murders, um, and the kind of the civil unrest that resulted from that was the one I would say there was no real training in.
right.
There was no, I'd been through an epidemic before, but not really been through like a viral epidemic before, but not through, as one of my medical students said, a video gone viral
Mm,
epidemic around racism and oppression. And so being able to, I think because I started early and it was really clear to people like what my values were, a really strong emphasis on diversity, equity, inclusion, and community health. I had already created one of my first orders of business was creating a new role for our department, which is a vice chair for diversity, equity, and inclusion. And we also have a vice chair for community health. And I think people pretty early on knew the kind of values that I had and the things that I cared about and how much social justice was going to be a part of my kind of tenure as leader of this department, that it didn't surprise people that I kind of stepped up in this moment to kind of take a lot of this on. But I will say that, without having, I didn't know my department that well still by the time all this started. I mean, I was still learning people and trying to understand where people were and what the values were, thinking how to reshape some of the values in the culture. So, if one of your first deep interactions with someone is during this moment where, your lived experience is traumatizing and you're just trying to like survive and think through it, just makes it hard to build trust and relationships there. But So I would just say that that was the harder, I think, of the two to step up and lead in. But fortunately, and one of the things that I think is really important for me career-wise is that coming back here to Ohio State, I have never had the kind of network of, in particular, Black colleagues that I have here, and in as faculty, as staff, as leaders. Um, I've had it nowhere else that I've been, and so for the first time, I think career-wise, professionally, I actually have this network of people that kind of share my lived experience, that kind of align from a values perspective, and have made it a lot easier to advance the work that we're doing in this area because there's so, I mean, I wouldn't say there are zillions of us, but there are a lot of us, and there are a lot of us in positions of influence that have really made the conversation a lot more comfortable.
That's an interesting point. So, a lot of the conversation, especially, well, not just on social media, but we see it, everything's on social media now, but about how do these large academic centers, how do these large organizations, how do these various institutions move their social justice and equity agenda in places that don't have a lot of diversity at baseline, right?
Yeah,
And speaking to a place that already has it, and how that synergy makes things a little bit not easier, but it changes how people feel about it. It changes when you have people in positions of leadership already. So, I mean, this is kind of a pivot from what our conversation is, but any advice? I mean, you've done some work on anti-racism training in academia, but any advice or insight on how people build that into their culture when it doesn't already exist?
yeah, yeah. You know what? And I'll before I answer that, I'll just say something that I think is really important also. So Dr. Quinn Capers was our former associate dean for admissions at Ohio State, and was strongly, sharply, and intentionally committed to diversifying the medical student class, to the point that I believe now Ohio State's College of Medicine is like number 4 in the nation in terms of African American matriculants, students, and we've got just tremendous diversity. I mean, I remember being one of 5 African American students in my class in medical school of 215 kids or young adults at the time. And just looking at what they have now, what this, coming back here almost 20 years later and seeing, what the students have and the kind of strength and numbers that they have, it's blown my mind. I think that intentionality is really important. But I will say, and he and I have talked a lot about this, like, we shouldn't let that be enough, because I don't want people to think, oh, well, they've got all these African American and other, underrepresented minority students in the school, so they're great and they don't need to do anything else. And that's a risk that you have even here in my institution. Like, well, we're doing great. I mean, look at all those students we have. Look at all those faces. And you can run the risk of thinking that you've solved the problem. But honestly, I would say that there's still tons of things to fix. It's not just about having the numbers. It's like, do they feel included? Are they empowered? Are they supported? Are they set up to thrive and succeed when they get here? Who are their mentors? Like, who is taking care of them? Who is attending to the unique needs of Black students in the College of Medicine? Who's attending to the unique needs of Hispanic students in the College of Medicine? Like, who is actually making sure that the underrepresented minority students are taken care of once they come? It's not just so. I do think that there's still a lot of work. And what is education, like, what is the curriculum teaching people? And how is it kind of, how are you leveraging those numbers to real change? So I just say that because I try to make sure that we keep ourselves humble. Another Reed scholar, Dr. Daryl Gray, and I have had the great fortune of working really closely together since I came back here. And he was already co-chairing what we call the Health Equity Steering Committee, which is a network of people committed to health equity across our whole medical center and across all of our health sciences colleges, which we have 7 of. And he's been leading that effort for quite a while. And I would say that when he and I talk, and our other colleagues that are in this space kind of talk about these things, one thing that we think a lot about is, we know that we're blessed to have what we have together. And we know that if Dr. Gray and I are together at a table, and Dr. Joseph or Autumn Glover, the people that are kind of in this space, or Dr. McDougall, Dr. Capers, if we're at a table and we're all together, we know that our voices won't be drowned out. It may not be the same when we're by ourselves. So for places that don't have those numbers, I just believe that, I mean, I don't think that this work can be solved by just, the African American, Black faculty and staff leading the work, and the other, yeah. There has to be ownership and allyship from so many people to be able to advance the work. So whether or not you've got, you know, our chief diversity officer, Ohio State, just was installed as a National Medical Association president a couple of days ago. And yeah, of course, we're lucky we've got that here. We've got that platform here. But if you don't, I mean, I think that a lot of other people do need to step up to advance the work. And I don't think that the work around the anti-racism work or the social justice or health equity work should be the charge of a few, minority faculty and staff to lead. And so, because I honestly feel that like everyone should feel like that's a problem. Like if we feel like if we're looking at our leadership tables and we see like we don't have a single woman or a single person of color here, or our student body does not represent what we know is out in our community. I think you should be appalled by that regardless of who you are, and you should be working to change it. And so I think we're blessed to have the kind of team that we have, but I also feel like that could mislead people to thinking that they don't need to do a lot of work because they have the numbers. But I think it's a matter of everybody kind of pulling their weight at those tables.
Makes a lot of sense. Um, it'll be interesting on how these things evolve, and I hope it is, like as you said, with intentionality, not just
Yeah.
dropping people of color in positions, and even the next thing, sometimes dropping people of color in positions and expecting them to do all the work, and that's also
Yes.
and so I think another thing that's important before we move away from this topic, and you talked a lot about your work in technology before. And so technology, of course, is also a big hot topic right now, and how to utilize technology because, we're social distancing, and because we are
Yeah.
trying to figure out how to combat COVID-19, but also how, is it helping or hindering our marginalized populations, right? So any insight and thoughts about the evolution of technology in this space in this current time?
Yeah. I think, I think that a lot of great things have happened with the way we've used technology in healthcare, um, more out of necessity than it is just, cool innovation. And
Right.
actually, Dr. Joseph and I, published something in JAMA about how do you still provide care and empathy to our most vulnerable patients in this digital era that has been kind of prompted by COVID. And I think, you know, we do have the risk of further marginalizing and further expanding the digital divide that exists, because as you start to require um, electronic skills, health literacy, but also telehealth literacy for patients to be able to engage in care with their physicians, you start to see so many different challenges of that. And I'll give you a perfect example. So my department transitioned. We'd already started a lot of telehealth work earlier on when I had gotten here, but it was just kind of accelerated. It was just a few people, champions and things like that. It accelerated, obviously, with all the things that happened during COVID-19. And I have, so right now, pretty much 80-90% of the care that I provide is done through video visits with patients. And it has been such an interesting learning experience for me. And number one, not all patients have access to the kind of smartphone technology that our video visit platform requires. And so I've had a number of visits that have started off with me trying to connect with the patient on video. My panel of patients is at our Eastside Hospital outpatient care clinic, so it's a large underserved population, lower health literacy, lower socioeconomic status, largely minority patients. So that's the population I take care of. And so I've had so many patients where I've tried to connect with them with video, and they're just technology can't do it. They're like, I don't think my phone really can do this. Can you just call? I mean, so can you just call me on the telephone and not start the video? So I've converted a lot of visits from like intending to do it by video, but to a telephone visit, which, makes me more comfortable. And, earlier on, the video visits we got parity in reimbursement for video visits similar to an in-person visit, but telephone visits were not reimbursed the same way. And, we've been staunchly focused on making sure that changes, because we feel like that in itself is a way to perpetuate potential disparities that already exist. Because for some of our patients who are elderly or who don't have certain technology, or who just don't have the capability to engage in those kind of more advanced technologies that are required for some of these kind of visits, if you say, okay, well, we think a video visit is just as is similar to a in-person visit, but a telephone visit is not, then you basically said that people that can only access you through just a phone call cannot get equitable care. And so, because you've discouraged us, you've disincentivized me from trying to do video visits on the telephone, which might actually be what people need. So there are a lot of things like that are policy decisions that end up kind of reinforcing and perpetuating or widening particular disparities. So we just have to be really conscious of that. Like, how do we make sure that those little things that they seem like no one really notices, and then you're like, wait, what? How did that happen, right? That's a whole segment of my population that will be marginalized because of that singular decision and how you're going to reimburse for telehealth. So I think that we've made a lot of advances, and I think people are finding that there are many different ways to get care and receive care, and the quality is probably still just as good. But we also need to make sure that we're not creating barriers for people just because of the policies that we're enacting to support that work.
And I think, and that underscores, right, what we talk about all the time is making sure you have people at the table when we're making policy decisions, they're interacting with these populations so that we can raise these conversations, right?
Absolutely. Absolutely. You can easily see how that could just slip by and people are like, oh, this is great. And then, you're like, wait, how did that happen, right? If no one's at the table kind of thinking about it. Or like language interpretation. That's a huge one. Earlier on, it was like, we have language interpreters when people come in person,
right?
And we have to figure out how do we replicate that in a telehealth environment, right? Like, it's not an optional thing. And if people are sitting there kind of not really aware of the impact of language discordance, or lack of concordance in language in healthcare. I mean, if people aren't at the table that think about those things, again, another one of those things that will just continue to happen, and no one's pushing back and saying, well, how are people going to be able to do this in Arabic or Spanish or whatever other language they speak that we don't, that I don't. So yeah, those tables are so important.
And, in continuing with the technology and virtual space, and we don't need to spend long on this, but as a mother of two children, if I get it correctly, we're talking a lot about sending kids back to school, and whether we send them to school in person, whether we send them to school online. There's clearly no right answer for this, but you're also a family physician, so I'm sure some of your patients are even asking you, like, what do I do with the kids, and is it safe for them to go? But any quick thoughts or insights or opinions on that?
This is a tough one. I mean, I think I completely empathize with parents across the country that are trying to figure out how to answer this problem. And one of the parents we have in my school district here, we have an African American parents group me, and so all the the African American families are aligned here. And someone sent something to the group the other day that said, if someone tells you, I've decided my kid is going to go back to school virtually only, then you should say, great job. I know that was a tough decision that you came to that. If someone says, my kid's going to go back in the hybrid model or, in person, you should say, great job. I know that was a tough decision to come to. So regardless of what they say, just recognize that people are struggling, and I really recognize it. And I know that people are looking to us. And I just tweeted about this morning as physician parents to see, like, what are you going to do? Because that will help me know what I should do, right? And how I should do. And a lot of people are reaching out to me about that. I will say that this is a real struggle for me. I feel like there are a lot of benefits of the in-person education. And for my children in particular, there are some things that there's nothing that I can do in this home that will replicate that experience. Even just the socialization and the skills, the life skills that are built through that socialization are really, really important. But I also think it has to be ultra safe. And our school district decided that, initially they were kind of teetering on what was going to happen with the masks, and they finally decided that 100% masks, no exceptions. And initially it was just teachers were masked, students optional. And fortunately, a number of us kind of were vocal about that, and then it became 100% masks. Everybody, students, teachers, with few exceptions, and very few exceptions. And then yesterday, our governor issued a statement that all K through 12 in the state of Ohio, children will be required to wear masks. And so now it's like, so I think just if they're gonna, I would say what's the most important to me is like, what is your school's plan? And if you can feel confidence in that plan, so our plan has 100% masks, 6 feet of social distancing in all directions for kids. So that means that the building capacity is greatly reduced so that we can't have 100% of kids. We can have less than 50% of kids in the school at any one time, which means staggered days, so partially in person, maybe 2 or 3 days a week, and then some, virtual. What are the school nurses going to do? How are they going to screen children that come to the office that are sick? What are the criteria for sending people home? How well will you be able to do contact tracing if, for whatever reason, you do have someone that's positive? So I think all those things are really, really important. Like, what kind of sanitizing situation are you going to have? Are you going to have kids congregating in spaces like in the cafeteria? What's that going to look like? What are the school buses going to do? What's recess going to be like? All those kind of things. I think I would say, to the extent that you can find out all of those details, like what are all the different measures that the school is taking to make sure that your children are safe, that the teachers are safe, that the administration is safe, that everybody's safe. I think those are the kind of things that I'm telling people to ask and not feel shy about asking, because I think that if the schools want to reopen and they want to go have people come on the campuses, like, they have got to be ready to protect our children and our educators. So that's where I am. I mean, I'm just, we're just working on kind of get the right plan in place for whatever that option might look like. We feel that if they can execute on the way that they've created this hybrid model, which will change depending on regional data, public health data from our county. If we start to see an upward tick again, then we'll start to move more remote. If we start to see things really get better, we'll start to move more in person. I think having that flexibility and willingness to change course based on what the public health data is showing us is really important as well. So I gave you no answer, but all I say is that I think parents should just really be pressing and pushing their schools to understand what their plans are. And if they don't feel comfortable with that plan, I've had people tell me that that have told me, like, I don't feel like what my school is saying is nearly safe enough, so I'm just going to have my kid go virtual. And I think that's a fair decision if you don't feel comfort in what you're hearing.
And that's what I've been hearing, talking to other parents and teachers and people in the education space, is trying to make sure there's a true plan in place with all these contingencies. And I think that's what's hard. I mean, that's what's hard in the pandemic. We don't know what's going to happen tomorrow. We don't know if things are going to get better.
Yeah.
What's going to happen. But trying to be as proactive about planning for all the contingencies up front, so that people feel comfortable that when there's something that's going to happen, and it's going to be purposeful and safe.
Right.
Well, as we close, I usually like to end on some moment of optimism. So, what do you think? I think we've learned a lot about ourselves as individuals, as countries, as a country, as physicians through this whole pandemic. But what are you optimistic about on the other side of this? After the aftermath of COVID, where do you think we can go from here?
Yeah, I feel really optimistic with the fact that I think that a lot of us have been like preaching and teaching and speaking a language that so many of our colleagues have not understood for so long.
Mm-hmm.
And I feel like, and I don't know what it is, and I don't know if, kind of the national reckoning that has happened, but it seems like now, like, so many people have caught up to where we are. And I have colleagues that have said to me, like, I don't know why I just never really realized, like, this is what you guys are living with, and this is what people are going through. It just feels so different to me than it has before. Like, I feel like, the people that are living certain experiences and the people that are just maybe learning experiences aren't even learning that much about them, or they're almost like getting closer in terms of where they are in terms of solutions. So I feel really optimistic that we're going to make some pretty radical changes in how we do things. And I can speak, more from the lens of healthcare than I can for everything. But I feel like even from a public policy perspective and a kind of a national mindset, a lot has changed in the last few months and changed for the better. And I think that we have seen allies that have not normally been there kind of stepping up and taking the lead in some cases on the fight that we're fighting. And so I feel really good about that. I feel like that's very different than what I've seen for a long time. And it doesn't feel like a lonely battle anymore. I feel like I feel so it's shocking to me like how comfortable I feel talking about really difficult things like race and racism with people that I can 2 years ago I could never have these conversations with, and as openly, and not like withholding my real thoughts, right? Like it just seems a lot different, or not kind of trying to sugarcoat things or make them comfortable for people, but just being able to kind of just be raw and real. And the fact that I'm able to do that makes me feel like things are a lot different. And I feel really optimistic that we'll be able to create some real, lasting, structural, systemic change as long as we keep our feet on the gas.
I agree. I've said that a lot. It's like now that we can say the word racism in mixed company, right? Like it's comfortable.
Yes.
That's a big change for me as well. Um,
Yeah.
well, thank you so much for joining us today. As always, I am inspired by you, and I enjoy watching your journey and seeing all the wonderful things that you have done, and I know that you will continue to do. You are a great leader. You're an eloquent speaker, so I always enjoy being able to talk to you and hear you speak. So I appreciate you taking the time to join us today, and good luck with everything.
Thank
As
you.
shares things evolve over the next few months. So I look forward to catching up again soon.
Yeah, thank you, and thank you for continuing to highlight the stories of the Reed Scholars. It's such a great effort. Really, really appreciate it.
Thank you. Thank
Doing great.
you. Well, take care.
Okay, bye.
Thank you for listening to Read Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.